conectarse en este momento a este importante evento. Mi agradecimiento a Eric Alexanderson y a Loa Meave por haberme invitado a estar en la coordinación de esta importante sesión que versará acerca de la insuficiencia cardíaca. Todos sabemos la importancia, la cada vez más creciente pandemia también. Ahora está de moda la palabra pandemia y estarán ustedes de acuerdo conmigo que la falla cardíaca en realidad es una pandemia a la que nos tenemos que enfrentar. Voy a hablar en inglés para el doctor Giron. Giron, thank you very much for joining us this evening. I mean, this night for you. I know this is late for you, and I do appreciate that you can have this time with us. Giron, you are a very well-known person, very well-known scientific in Mexico. And let me shift to the Spanish in order to explain some of your CV, ¿ok?
Yeah, sure.
Amigos, como ustedes saben, el doctor Jerome Bax es una persona extraordinaria, tanto como persona como científico. Él es cardiólogo. Él fue el past president de la Sociedad Europea de Cardiología e hizo un extraordinario papel. Ha recibido diferentes reconocimientos y es uno de los europeos que trabajan arduamente también con el American College of Cardiology, por lo cual ha sido creador de reconocimiento y un trabajo muy importante. Él es el jefe del departamento de imagen, a su vez del departamento de cardiología de la Universidad de Leiden en Holanda. Jeroen, I want to welcome you. Now you can start with this important topic on what information is needed in severe heart failure. I told to my colleagues in Mexico that the pandemic word is, very common in the current days. And when we talk about heart failure, pandemic is also present. We see every time the increasing rate of patients with heart failure, both with severe dysfunction and those with present heart failure. So you can start when you want. Welcome and thank you again.
Okay, so I'm gonna do this talk, and I have another short talk if we have time on my view on heart failure with preserved ejection fraction. Let's see if we can do that also. Depends a little bit, you indicate if you have enough time. So thanks for inviting me, and it's not night, it's 11 o'clock, so it's quite decent. And if you look here in my room, you see that I never unpacked any of the boxes when I moved in here. So maybe I'll do it now that there's nothing to do anymore here. So we're going to talk about what information is needed in severe heart failure. And I always like to go with this sort of patient examples. And this is a man, 62 years old. He's got an infralateral infarction. He got a repeat inferior infarction. He got an anteroseptal infarction. He got a bypass surgery. And then later on, he has non-sustained VT. So nowadays, we're very aggressive with the VTs. ICDs go in quite easily here. He has comorbidities, diabetes, pulmonary disease, and severe kidney failure. He presents with the reduced exercise capacity, New York class 3. He has a dizziness, hypotension. He has a blood pressure of 90/65, which is not a good sign in these patients. And he has a holosystolic murmur, which is for sure mitral regurgitation, which many of them develop. So I put like this. I think I've been showing you this sort of presentations before. I like to systematically check these people on the information that you need. So if you look at what you need, I think what is important is LV function, LV size. You want to know, does the patient have coronary disease, ischemia, and or viability? This one has for sure coronary disease because we know the history, but it can also be that if a patient comes in, so I tell you I had on my outpatient clinic last week, a woman that I know since quite long time. She has had chemotherapy for cancer. The angio was in the, let's say 2007 or so, was normal, dilated cardiomyopathy. But I would still do in this woman another angiogram just to rule in or rule out coronary artery disease because now she presents with much worsening heart failure. So I think it's very important to see what are you dealing with. Do you have coronary disease or do you have non-coronary disease? Does the patient have severe mitral regurgitation? That's very important nowadays. There's a lot of focus on repairing the mitral valve, either surgically or doing clips. I think ICD is important. With ICD comes also CRT. And these are the questions that you need to ask yourself. Why do we do this? This is how we have built our care tracks. All these patients are treated when they come in by the assistants, by the younger physicians following these questions. And then you collect, I should say, systematic information all the time. So one, you think in patterns, you collect the information that you need to treat the patient, but also what we do with all these sort of care tracks, all this information is stored. So from these big registries that we're building, we can then do scientific derivatives. But always think in terms of pathophysiology. You see here in this old slide from Harvey White, 1986, that once the ejection fraction goes down, your mortality goes up very steeply. I think what is important to realize is that we have not gained so much over the last years. We have all these new drugs, but this curve still stands. As soon as the patient go, let's say, below 25%, the mortality is sky high. I just did a sort of lecture on the new heart failure drugs, the Vericiguat trial, the Paradigm, and the DAPA-HF, where you see still that in these very sick patients, the mortality is very, very high. I think it's also important to realize, let me see if the things move. I'm sorry that they don't move. I don't know why that is. So you see here our patient. Our patient has a big anteroseptal infarction and an inferior infarction, as you see. In all of these patients, we use intravenous contrast like immediately so that you can see if there's thrombi. Most of these patients with big apical aneurysms like this one have mural thrombi, but you want to know if there's no protruding thrombi so that they do eventually a stroke, which you see on the bottom right, that it's quite easy if you give the contrast to pick up a thrombus at the apex there. So we're very liberal, very easygoing with contrast because it helps us a lot in the daily practice. With echo, and you see here again that we use the contrast really well. They calculate quite nicely. So we're moving away from 2D to 3D. Of course, you would like to have, and I speak to you, Aloha, you would like to have this sort of pictures in every patient. Then life would be fantastic. We do that when the question really comes, do you need an ICD or not? Because we still go according to these guidelines. If your EF is below 30-35%, you get an ICD. But ideally, you would like to see this in every patient. And I'm always so interested also to see how well you can see, for example, in the middle picture, the pulmonary vein inflow. I'm sure you see that. And also the right side of the heart, the trabecularization, you see almost everything. I like it very much, but we cannot, we do about, I don't know, 200 echoes a day. So we can never do 200 MRIs a day. So we save this when the question is really, what is the ejection fraction? We can also start doing that with CT. This is already an old picture. This is a non-ischemic dilated cardiomyopathy of a very young guy, less than 30 years old, who presented with embolisms. And we were checking for cardiac thrombosis. He didn't have, but you see here exactly how very precise you can see the trabecularization, the papillary muscles, etc. This comes still at relatively high radiation. So that is the reason why we don't do that in all patients. So why do we need LV function and LV size? We need that because assessment of ejection fraction, assessment of volumes, because they're gatekeepers for ICD or CRT, but also very strong prognostic indicators. I think what I like personally, I like the volumes, but I like even better, very simple LV dimensions measured at the apex, at the base, because with echo, you never really know exactly where you cut. But if you do on an M mode these LV dimensions, that's pretty indicative. So I like to see the LV ESD and the LV EDD, very simple parameters, but still quite strong. We see that the field is changing. We're using more and more this strain with echo, where we can measure actually the active deformation. In this picture here, you see the arrow on the right, that this is the longitudinal strain. So this is up and down strain. You have 3 ways of strain. I'll show that, I think, in one of the next slides. But the point I want to make here is that if you look to the slide where the arrow is, that all the different parts in the ventricle have different colors. So the different colors correspond to the curves that you see below there. Now you see that they all peak at the same time. That means that there is a completely synchronous ventricle. You also see that the peak is negative. That doesn't mean anything. It's just how they plot this. And that's also why the global, because this is the global longitudinal strain, is expressed as a minus. But just forget about the minus, we'll get there in a second what it means. You see that the dotted curve in the middle is actually the summation of all the different parts. This is what I like very much. This is what these modern echo machines for you do. So they have a probe where you can capture the 2, the 4, and the 3 or 5 chamber with one shot. And so from those pictures, you calculate sort of bull's eye plot, what you know from nuclear cardiology. And you see that down there. And this is the global strain picture of this heart. And you see that in the center, it says -24. And you see that the apex has a little bit less, or the base has a little bit less, -17, -19. But it's all red. And if you look now carefully at the slide, you see that I put a red box around the global strain, which says -20.4. That is the strain of a normal ventricle. Again, the minus is only the up and down, so forget about that. But a normal heart has 20%. This is what you see in controls. Again, here the controls, everything red, everything homogeneous to the right. And it says -19. So -19, -20 is normal. Now we go to the middle panel. The middle panel, you see that the anteroseptal part, because you see where the right ventricle inserts. So the anteroseptal is let's say from 3 o'clock till, let's say 8 o'clock. That's all red. So that's all normal. But the problem here is in the inferior wall, lateral inferior wall, because it's rotated slightly, this thing here. And this is an acute inferior infarction. And that correlates with a strain, global strain of this heart of about 14%. A global strain of 19% is an ejection fraction of, let's say, 60, 65%. A global strain of 14% corresponds to an ejection fraction of, let's say, 40%. And if we go all the way to the other extreme, you see there a strain which is totally blue and pink, and the average is really nothing. It's 7%. 7% corresponds to an ejection fraction of, let's say, 15%. This is a patient with severe heart failure. Okay? So you can correlate these strains to ejection fractions. But if we have time, I'll show you also why it does not always correspond to ejection fraction. But okay, we'll get to that. We're also looking at these flow patterns. These flow patterns are giving us an indication of how the blood is flowing in the ventricle. We started working with this quite some years ago, and we have the feeling that it gives you an indirect picture of how the ventricular function is, but we're not that advanced yet with that. So if we go to the next step now, our second question is, does the patient have coronary disease? And if he has, does he have ischemia and viability? So here's the angio of this patient. It's very clear that he has extensive triple vessel disease. But we can also nowadays do just a CT scan. If I have a patient like this, what we're just discussing, I'm not going to mess around with any CT scan. I just do the CT scan basically in intermediate to low likelihood to rule out. But in heart failure, it's also not so useful because your heart rate needs to be low for a good picture. And the patients in heart failure usually operate at a heart frequency of, let's say, 100 beats per minute, sometimes 110. So you don't get so good pictures. But you can use it as an alternative. That's why I'm showing it. Of course, if you see this in your patient, then you know that it's normal. You exclude coronary artery disease. So if you cannot do an angiogram for certain reasons, sometimes the kidney is so bad that we like to do CT, of course, then it's good to see this, and it immediately makes the diagnosis of a non-ischemic cardiomyopathy. We are very still keen on working if we assess ischemia with nuclear scans. They're easy to do, the reproducibility is high. Here you see a very striking example on the left where you have stress images and rest images. It starts with the short axis, it goes then with the vertical long axis, and at the bottom is the horizontal long. It's very clear that at stress there is a big defect which fills up completely at rest. If you then look to the polar plot on the right, then you see that you get the percentage of the ventricle that has ischemia, which is about a third in this patient. That's very severe ischemia. Now, when I showed these pictures before, we never had any discussion. Everybody agreed that this patient needs to be revascularized. With the current thing of the ischemia trial, makes you wonder a little bit what you need to do. And I think the books have not been closed about that. But I think what is equally important in the whole discussion is that many people say that it doesn't matter anymore what I do. I can treat them all medically also. But a lot of patients you treat for symptoms, and that start to become more and more clear. We all agree with the valves that if you have severe mitral regurgitation, that you can do a clip to treat the symptoms. Most likely, you're not going to make them live so much longer. So I think if you see severe ischemia, independent of what, I'm still very much in favor for revascularization, just to simply take away the symptoms. Then the question is there viability? And you see here this meta-analysis that we once did. And you see on the left, the patients are viable. And you see if you revascularize them, that the event rate is the lowest. Whereas if the patients are viable and they're treated medically, that the event rate is high. You also see that if the patients are non-viable and then revascularized or medical, it doesn't make much difference. We all know the STITCH trial, and we've seen the short-term outcome in the New England, and then we saw the midterm, and we also saw the long-term. And recently, it appeared that the viability still had value if you waited long enough in this trial. So I'm saying, I think if a patient is relatively complex, multi-vessel disease, bad function, I like to see ischemia plus viability in the discussion on revascularization, independent of results of trials, because we have seen quite often that if you have a very big area of viability, you revascularize, that you can expect at least some improvement in function, which in a case like this, I think is important. How do you do it? You can do nuclear scans. On the bottom, you see our patient where we started with. You see his inferior infarct there, and you see his anterior infarct. And you see that the FDG scan on top shows a lot of tracer uptake. So if we look at picture 10 at the top row and 11 at the bottom row, then you see that there is a big area where the perfusion is gone, but there still is a lot of glucose uptake. And that indicates that you got very low flow there, and that basically the glucose metabolism is still preserved. So I think it's worthwhile revascularizing, but this patient of ours had already one surgery, etc. So it all depends on systematic testing and then putting it into context of your patient. I like to do an MRI also. So in these patients, you have the delayed enhancement, where you can see on the left panel a non-transmural scar in the lateral wall, whereas you see in the right panel a transmural scar almost in the anterior wall. The MRI gives you superb delineation of what is dead, but it doesn't tell me much what's going on in the black part. Is that normal and alive, or is that jeopardized and alive? If it's jeopardized and alive, you would consider revascularization, whereas if it's normal and alive, you probably would not think about revascularization unless you can induce ischemia. That's why the total picture is so important. This slide I got from Marcus Schweiger. And you see on top, you see the MRI, in the middle you see the PET scan, and now you see at the bottom the PET MR. We now start to see more and more people who are working with this PET MR. It's coming. And it's specifically interesting in diseases such as sarcoidosis and amyloidosis and so, where you want to have anatomy and you want to have something not so much function, but more biology of the myocardium. So that is a totally different way of thinking. I think that every disease has three components. You have anatomy, you have, oh, it's telling me that I need to go home. You have anatomy, and then you got functional consequences. So let's say the anatomy is a stenosis in a coronary artery. The functional consequences is ischemia. But then there's another very important part, and that's the biology of the myocardium, or the inflammation, if you like. And that's why I think the FDG tracer or other tracers as we're developing now are so important, because a lot of these systemic diseases like scleroderma and amyloidosis and sarcoidosis and so on, they have these different components. And in those, the inflammation component's very important. So I think not so much for viability assessment, but I think for all the, I would say, rare diseases that we're seeing nowadays, that is very important. And you see the survival, or the revival, I should say, of the PET scanners plus CT or PET scanners with MR. They're super good in assessing these things. Well, our patient for severe has, for sure has severe mitral regurgitation, because you could hear it already with the stethoscope. And I think we know these sort of pictures that if you have in the bottom line is the patients with severe mitral regurgitation, and in the top line, the dotted line, you see these are the ones without MR. These are patients with heart failure, and you see that if you have a severe MR, that the outcome is really not good if you leave that alone. You know it, because if the patient come in with severe MR, that's why we're now more aggressive with mitral clips, etc. If we cannot operate them, we want to fix it, because this is not only for longevity, but much for symptoms. Because if you ask a patient what's very important for you, a heart failure patient, they say not constantly pulmonary edema, because it feels like you're drowning in your own fluid. So I think MR is a very important part of the diagnostic, therapeutic, and prognostic workup of these patients.
Let's go back to our patient. You see here a transthoracic echo on the left, and you see that there is a significant mitral regurgitation. On the right panel, you see a transesophageal echo in the same place.
Yeah, what happened here, this is an older presentation, so I have already spoken in the pictures. I didn't know that that was the case. So what you see here is that we need a transthoracic and a transesophageal. It's very important to quantify also this, because the quantification of that is actually very important for prognosis, and also how can I treat. So that is something that we start to pay more attention. So in this patient that we have, and he comes with severe MR, I'm sorry that the videos don't move, but if you would see that's very severe MR, then you would see actually that it's really an important part of the diagnostic and prognostic workup. If you do bypass surgery on a patient like this, and you don't fix the mitral valve, it's a mistake, because the patient will in 2 years die of recurrent heart failure. Let's see what else I have.
And Dr. Lancelotti, as you see here, has shown
I need to double check this because I got these things in here. So 1 second, I'll fix it right on the spot. I think the rest should be okay. Yeah. So the quantification of mitral regurgitation is extremely important. And we start to realize more and more that you need to do this routinely. Echo is okay, but it has a lot of limitations. So ideally, we like to do that with a more advanced technology such as MRI. If you do quantification of mitral regurgitation, I like best the semi-quantitative parameters. So here you see the vena contracta, which is the jet area as it leaves the effective regurgitant orifice area. If it's more than 7 millimeters, it's significant. Now, you ask me, what about if it's 6.5 millimeters or if it's 7.8 millimeters? The ones of you who do echo know that this is not something that you can easily assess. It goes beyond the resolution. So in general, 7 is a lot and you need to think about doing something about it. The other parameters, the other panel there shows the systolic pulmonary flow reversal. What is that? That is actually the blood coming back in the atrium and then going straight into the pulmonary veins. And if it goes very deep in it, it's actually inhibiting the blood coming back through the pulmonary veins in the atria. And that creates the systolic pulmonary flow reversal. Those two very simple, accessible parameters are very diagnostic of severe mitral regurgitation. Of course, we got this. This is the PISA, proximal isovelocity surface area measurement. And you see here that we need different parts. So we need in these two formulas, the first formula is EROA, which is the effective regurgitant orifice area. I always call that very simple, the leaking hole. How big is the hole that where the blood leaks back into the atrium? You see that we need various variables. One is the radius of the first isovelocity surface area. That's an echo terminology. Then you need the velocity aliasing, which you see in the middle. And then you need the velocity max with your continuous wave signal. And then you need the VTI. With those parameters, you can measure the effective regurgitant orifice area and the regurgitant volume. And those two are becoming very, very important for the discussion, should I do a mitral clip or should I not do a mitral clip? This works very well when you have a central jet. If you have an eccentric jet with the prolapses, etc., then all this quantification does not work. I like this. We've worked with this quite some time, and this speaks to you, Aloha. This is an MRI, and I think it's quite beautiful what we can do with this nowadays. You can do in one session, completely assess the velocities of, with the velocity encoded imaging, we can assess the 3D flow quantification in all the valves in one acquisition. So you see there on the top mitral valve and tricuspid, then you see aortic valve, you see the pulmonary valve. Now we're talking here about mitral regurgitation. So I'm going to take out the mitral regurg, and you see here the curve shows exactly the forward volume, the backward volume, and from that you can completely specific calculate the regurgitant fraction. There is a lot of discussion at the moment. What is important for prognosis? What is important for treatment? What justifies mitral clip and what doesn't? And it seems at this moment in time that the best information is given by MRI. We also switched largely from 2D echo to 3D echo. And what you see here has nothing to do with what we're talking about, but you can see so much better the annulus and the leaflets, but also big prolapses as you see on the left side. And the interesting thing is that you can now look from the atrium into the ventricle and from the ventricle into the atrium, things that we could never do before. This is the 3D transesophageal echo, which I think is now key in guiding decisions for any sort of heart valve disease, if it needs surgery or not, or if you can do clips or other procedures. We've discussed now LV function and size. We spoke about ischemia and viability. We spoke about severe MR. The next question that we have is, does a patient need an ICD? This is a very difficult discussion, and it has been going on since MADIT 1, basically. Patients with a previous infarction, ejection fraction less than 30% or 35, doesn't really matter, benefit from ICD in terms of improved survival. With an ICD, theoretically, you cannot die in terms of sudden death. So this was the data taken from the MADIT 2 trial. You see there are 720 patients, follow-up 21 months. In the 21 months, there were 35 patients that had a shock, but there were 65 patients that never had anything, or 65% of the patients. We have also looked at our big databases, and we see basically something like 75-25 in longer term follow-up. So that means that only 1 out of 4 ICDs is actually active for the patient. But it is very difficult for us to tell which ones are going to benefit from the ICD, which ones are going to have these ventricular arrhythmias, and which ones do not need it. And as long as we cannot make that diagnosis, there's actually no real way of selecting the patient who needs one and who doesn't. And so we give everybody an ICD. This is a slide that I got from Bill Stevenson. And you see here the pathophysiology, you see here the scar, and you see also the concept, which is the area between, around the scar, transitioning to the normal tissue. And the idea is that specifically that area is very sensitive to very fast VTs. So it's the border zone between scar and normal myocardium. And it's in that area where the very fast VTs get elicited, and those VTs are very lethal. So we published in, I think, 2008 or something, this way of looking at things is just a delayed enhancement. And you see a patient with a very big scar from the septum, and you see that I put it out there in black. I circle it for you. It's a big anteroseptal infarct. And if you now look at the other part, then you see actually that we can measure the density of that scar. And you see that I pointed out there. The red scar is completely the border zone. It's completely the core. But at the shoulders, where it transitions into the normal tissue, you see that the density, that's where the yellow is, that it is much, much different in the density of gadolinium enhancement. And what we did afterwards is that we looked, and we call it infarct gray zone and infarct core. And you see that this infarct gray zone in green, if it's very little, that these patients have almost never shocks on the ICD. But if it's very big, and you see that it's here more than 16.7 grams, that was the medium in this study, that those patients have significant amount of shocks. So this tells us that patients who get more ICD shocks as a surrogate for sudden death, then basically it tells us that we can potentially identify the high-risk patients, although it's not 100%. I think what I would like to conclude with this is that a severe heart failure patient, you need very complex information. What you see happening when these patients come in the hospital, that everybody starts to do everything, which is not good. I think you need to work systematically and select and collect the information that you need. So complex information is needed to determine and individualize therapy. You cannot treat these patients all the same. And so this is actually calling for tailored medicine, personalized medicine. And so we have these care tracks. We give them these different information collections that I just showed to you. This can be provided by multimodality imaging, and it permits individualized patient treatment. Of course, this is expensive. Of course, a lot of imaging comes here. But I think if you do it systematically and you start to treat them systematically according to your findings, you will never have that you said, oh, we didn't do this or we did too much of that. And I think that's really key in the treatment of these patients. This was my last slide. Sorry for the inconvenience of these few texts in there. Sometimes I've forgotten where I have that in them because I do these talks many times. But I think the bottom message here is that it's very important to work systematically. I don't hear you.
Are you able to?
Yeah, now I hear you. Mm-hmm.
Okay, thank you.
Would you
Excellent,
like,
very good, very good lecture. I would like to, Pedro, do you have some questions?
Take a look at the HFpEF also, or you just want to leave it to this?
If you want to do something of the preserved ejection fraction, maybe it could be okay. I mean, that way we finish all the spectrum.
Okay, let me see if I can find that real quick here.
Yes, perfect.
Okay. This has been a very interesting lecture about the use of multimodality imaging. If Dr. Bax is able to find the preserved ejection fraction heart failure, would be also great to have a complete spectrum of heart failure. The two big presentations are patients with preserved ejection fraction and patients with low ejection fraction.
How do I do the screen share with you?
Okay.
Okay, you have to go. Yes, you go at the bottom down.
Green.
And it says green. There is a green case, and it says share.
Or am I disconnected of your Zoom?
Can you see it?
It looks like I'm disconnected of your Zoom. Let me see if I can connect that real quick.
Okay.
No, it should be this one. Should be this one. I got it.
Okay.
Okay. Let me see where it is. It's here.
Yes, exactly.
And you can see it now, right?
Yes, perfect. Yes.
Okay. So this is, I like to put these things very simple. So I say heart failure and echo, how to assess systolic LV function. We spoke about that before. The cornerstone is ejection fraction, right? So if we look at two hearts here, an ischemic and a non-ischemic, they are easy to assess the ejection fraction. I also told you that I like to give the contrast. This gives me much better information on what the ejection fraction is and to measure it. But ejection fraction basically is nothing different than the change in volume. It's volume that is in and the percentage that goes out. When we start to introduce heart failure with preserved ejection fraction, the question immediately came, okay, how do I assess that? So echo and ejection fraction, no. So how to assess LV function in those patients? And I put there when everything was not simple anymore. So what do we measure in heart failure with preserved ejection fraction? We need other parameters, more subtle parameters probably, of LV systolic and maybe diastolic function. So we got these techniques. We have this tissue Doppler imaging, and we got this strain imaging, which we addressed already a little bit in the previous talk. So the strain can be in three directions. It can be in the longitudinal, it can be in the rotational, and it can be in the inwards. The one that we work with, which I showed in the previous talk, is this one, the longitudinal. And I explained this to you, that we move away from regional and we try to put it as global, and the global gives it a number. And I explained this to you also, what it looks like a normal, what is an infarct, and what is a heart failure. Ejection fraction is not exactly the same as global strain. You see here that there's a pretty good correlation, but it's not exactly the same. So what do we measure then? How do we measure this? I'm going to take you to a couple of slides. Does these pictures move when you see them?
No.
No, maybe if you can take them to, so we can make a big.
I think the problem is that I do the screen share. That's why the movies don't work much.
Okay, that could be the reason. Okay.
Yeah. But okay, we can continue because I'm now going to give you a series of examples of patients with preserved ejection fraction which are not normal. And we need something else to assess that. So this is patient chemotherapy. We all know these examples. This 21-year-old man, anthracycline for lymphatic leukemia. You see that the echo is totally normal, but if you see the ejection fraction 60%, but you see the global strain, specifically at the bottom there, is not 100% normal. There is subtle damage in this heart, and his global strain is 18%. And I explained to you that 20% is normal, 18 is just subnormal. EF is normal, but there is something there. This one is where everybody looks at the moment, is amyloidosis. Ejection fraction of this patient is 66%. But if you look at this bullseye plot there, you see already that this is not good. This is not 100%. So this global strain is 11% only in this patient. So he has a perfect ejection fraction, but his global strain is not good. So this is making the case that ejection fraction and strain are not exactly the same. And if you look at these prognostic implications, then you see the one in the dashed curve with reduced strain, they have the worst outcome. Now let's take another picture, hypertrophic cardiomyopathy, ejection fraction 65%. And this is the strain of this patient. It has a global strain of 8% only. So there is a mismatch between ejection fraction and at the tissue level, the fibrosis level, what's happening in the heart, because that is probably what I think that this is reflecting, the fibrosis in the myocardium. Here's another one, sarcoidosis. You see very clearly on the MRI the areas of inflammation and scar. The global strain of this patient is 17%, so it's not normal, subnormal. And here is another one, and this is one everybody knows, aortic stenosis. Patient has a surface area of the valve of 0.9, so very severe stenosis. Gradient is about 60. Ejection fraction is 62%, but the strain is only 13%. And you see that the strain is the most reduced in the septum. And if you now look to the black and white pictures, you see that there's significant septal hypertrophy. So most likely, with the hypertrophying of the ventricle in the septum, fibrosis is induced. And that's what you see reflected on the strain images. So to understand why the strain is reduced, abnormal functional is the consequence, what I say, of abnormal anatomy. And the structure is fibrosis. So we got anatomical imaging and functional imaging. This is the fibrosis. I like really this article. It shows the MRI with the T1 mapping is probably telling us a lot. Here you see on the left, the reactive interstitial fibrosis. And you see there hypertension, diabetes, aging, and valvular disease. And what you see there is that there is in between the myocytes, this sort of pinkish, brownish, purple things. Inside in there, there is actually place for fibrosis. If you now go to the bottom line in the middle, you see that there is much more than fibrosis. Now there is big areas of scar information, scar formation. So now how do we bring this all together? The myocardial fibrosis, as you see here, I think this is another one of these really good articles. On the top, you see the normal myocardium. You see the normal myocytes, and in the middle is the late gadolinium enhancement, LGE, is totally black. So there is no scar. And then you see the T1 mapping in colors, but what is more important that each time there is ECV, extracellular volume. What is extracellular volume? Most likely that relates to the fibrosis in these patients. Now, if we go one layer down, you see there diffuse interstitial reactive fibrosis. And you see that there's becoming more space between the myocytes. My late gadolinium sees nothing, it's completely black, but the extracellular volume has gone up to 32%. Now I go to the third layer, infiltrative interstitial fibrosis. The late gadolinium enhancement shows nothing, but the extracellular volume is now in the direction of 38–40%. And if you look then at the far bottom, focal or replacement fibrosis, you see that now finally the delayed enhancement comes positive. So there is more than just diffuse fibrosis, it's confluent, and it's now forming scar formation, and the extracellular volume remains at about 40%. So what is my theory about this? You have here three rows, and you have here three columns. Let's speak about the columns. First, we look at the normal myocardium, and you see below there N, and nothing. That means the normal myocardium has a normal native T1 time, has a normal extracellular volume, and has no delayed enhancement. We go to the middle column. It says reactive fibrosis. You see there that the native T1 is increased. The extracellular volume is increased. There is fibrosis formation. You see that the delayed enhancement is not there. So it is diffuse fibrosis and not big scar. At the end, the third column becomes replacement fibrosis. Now the native T1 is really different, is really way up. And the extracellular volume is huge. And now the gadolinium becomes positive. You got a lot of fibrosis coming together now as really scar tissue. If we assume that this MRI is the anatomical component, then your strain and your tissue Doppler is the functional consequences of that. So now we look again at the columns, same as what I just had for the MRI. We look again at the columns, and you see the first column is the parameters, then comes the middle column is normal myocardium, then comes reactive fibrosis, then comes replacement fibrosis. So I say the normal myocardium has normal strain. I'm only going to speak about the lower two rows. Has normal strain, has normal ejection fraction. The reactive fibrosis has slightly reduced strain, but has a normal ejection fraction. And once the replacement fibrosis comes in, then you see a lot of reduction in strain and a significant reduction in ejection fraction. And this, in my feeling, explains why you can have fibrosis, strain down, ejection fraction normal. And you also bring together the MRI with the functional consequences of this MRI. So if you want, if you don't have an MRI, you can use the tissue Doppler or the strain measurements as a cheap surrogate of the fibrosis or big scar. And how does this then relate to diastolic dysfunction? This is my last slide. Once I started thinking this, probably the more fibrosis, the stiffer the ventricle, and that's what in many of these diseases is happening, the more relaxation abnormalities. And I think that the artificial staging of diastolic dysfunction in grade 1, 2, 3 may be replaced by a continuous score on the extent of fibrosis or the reduction in strain. And so you could even say that the artificial differentiation between diastolic dysfunction and systolic dysfunction, you could see it as one continuum, with at the far end, the heart failure with preserved ejection fraction, and at the other end, the first talk that we did about the heart failure with severely reduced ejection fraction. This is just hypothetical ideas, but it makes sense. And with these smarter tools that we have to measure these damage, very subtle, going on to very severe, it gives us the possibility to get more insight into this. That's why I wanted to link this second talk next to the first talk because it gives you the complete picture of heart failure. There's a lot of things that will be proven in the future to be different, but I think the idea of thinking makes a lot of sense. Thanks very much.
Perfect.
Thank you, Dr. Jeroen. There are some questions for the audience.
Okay.
Everybody, we did enjoy your topic and how you were guiding the people on what to do with the different techniques of imaging in patients with heart failure. One question is, do you usually use contrast echo in those patients with dilated ventricle in order to rule out the thrombi?
Yeah, we do that quite often, yeah, because let's say that there are routine patients coming that you're checking at your outpatient clinic every year to check their ejection fraction. It's not infrequent that you pick up thrombi. Now, if you use the contrast, you're going to see a lot. But these mural thrombi, you don't need to worry so much about. But it's this moving thrombi where it's, of course, very important that you do something because it can easily go loose and go to the brain and create a stroke. So I think the contrast is something is very simple, easy to do, and it gives you a lot of information. So your answer is, yeah, we do that routinely.
Okay, we already know the role of the global strain. And what do you think is the future of ejection fraction? We already know the limitation that that parameter
Well, I give you another limitation of ejection fraction, okay? A couple of years ago, I was looking at an MRI of a patient with severe mitral regurgitation, like the one that I showed here. And again, sorry that the movies didn't work. That's because I think it has to do with the screen sharing or something. But this heart was doing nothing than this, okay? Large ventricle doing nothing more than this. We had calculated the ejection fraction to be 35%, maybe more. The radiologist who was sitting next to me said, this cannot be. And I thought to myself, no, this cannot be because this is not 35%. What I'm seeing here, this is 15%. But this patient had severe mitral regurgitation. And if you calculate your ejection fraction according to these formulas, then you calculate the volume that goes out as compared to the volume that stays in.
Yeah.
And it's true because half of the volume goes out, but only very little goes forward in the aorta and all the rest goes backwards in the atrium. So that brought us to the fact that you can better speak about stroke forward volume rather than ejection fraction.
Okay. Do you have myocardial performance index have a role in the current, imaging arena?
Yeah, I like it very much because it gives you a very clear idea about the performance index of the myocardium. Yeah, this is an older parameter, but I like it.
Yeah, in both ventricles, right and left ventricle?
Yeah, absolutely. I mean, we just had a discussion here yesterday about this. We did not address in any of this talk here the right ventricle. But I think personally that the right ventricle is the end stage of everything. We wrote in the Lancet a review last year about staging the disease. So 85% of the patients with dilated heart failure is probably ischemic cardiomyopathy. So how does an ischemic cardiomyopathy work? You get 1, 2, 3, 4, 5 infarctions and we do PCI, bypass, etc. But eventually more and more scar becomes in this ventricle. So what's the ventricle going to do? It's going to dilate. When the ventricle dilates, the mitral annulus dilates. If the mitral annulus dilates, you get mitral regurgitation. So that goes back in the atrium. The atrium gets overloaded. It's a very thin structure, gets overloaded, start to dilate. Atrial fibrillation comes. If this goes on, then you get actually pressure going down through the pulmonary vasculature and you start to increase your pressures. So your right ventricle is going to struggle. And that means initially you see dilatation of the ventricle and you see dilatation of the tricuspid annulus and tricuspid regurg comes. And we've published recently in this big cohorts that we have, if your right ventricular function goes down, it's a really point of no return, then these patients die. So this cascade that I just described, left ventricle, left atrium, right ventricle, right ventricle is super important because that's the one that actually tells you how far you are in this cascade. And this also then advocates for much earlier intervention. So when we talk MitraClip, for example, you could think about that we should not let it go until the ventricle is this big, but that we do it a little bit earlier. And that is also this discussion in the COAPT trial versus the MITRA-FR. And what we feel, the MITRA-FR was totally negative in effect on mitral regurgitation and survival, whereas the COAPT had a very positive effect. So what's the difference? I think that the COAPT had lesser damaged ventricles and therefore went in earlier. RV function was still relatively preserved, whereas MITRA-FR was much sicker patients, often with a severe reduction already in RV function. So the RV for me is the gatekeeper of, are you on the right side or on the wrong side?
Okay, thank you. There's one more question. What do you think about the Almayer heart failure and the use of MIBG in these patients?
Yeah, I think that's a very good point. Unfortunately, this trial was stopped prematurely because the patient could not be enrolled. What is the Admire HF? What was the Admire trial about? So this is a tracer that indicates, it's called MIBG, and you can assess the myocardial innervation and denervation. So both ischemic and non-ischemic cardiomyopathies show to some extent cardiac left ventricular denervation. The more of areas of denervation you have, the higher the likelihood is that you get ventricular tachycardias. So if we now talk about this selection for ICDs, the trial was set up to look if you have perfect or good innervation, almost no defects, that you might not need an ICD, whereas the ones that have more problems with innervation, more denervated areas, that they have a higher likelihood of get shocks on the ICD and arrhythmias. That way you could select, this one gets an ICD, that one doesn't get an ICD. The same thing actually what I showed you with the MRI, that you can distinguish by ones that have very little shocks and one that have a lot of shocks. Unfortunately, this trial was stopped because the patients were not enrolled so easily. And that is because we have this rule that if a patient has an ejection fraction less than 30-35%, he's entitled to an ICD. But at the same time, I showed you that the shock rates are very, very low, sometimes up to only 15% of your patients. But I say immediately, you will always miss 1 or 2 or 3 or 5 patients in big cohorts that benefit from the ICD. So this is is not only a statistical question, it's also a conscious question. If we have ICDs to prevent sudden death, and you want to give everybody an ICD, then certainly nobody's going to die of arrhythmic deaths, right?
Right.
And if you want to then go in this selection, you will always have a couple where you don't give an ICD and eventually something happens. So this is the question, what's underlying all this discussion. But at the same time, we see that the shock rates and the benefit from ICD is rather limited. But in the ones that need it, it's super successful, of course. So this is a question that's difficult to answer. A lot of people, but you can alternatively, you can turn it around and you say, well, also probably more patients with an ejection fraction above 35 die of sudden death on the total mortality as compared to the ones with an EF lower than 35. So you could, if you could identify high-risk patients, you could use it to select patients with a high risk of sudden death in an ejection fraction above 35%. So I think MIBG certainly has a future, but they didn't continue the trial.
Okay, thank you. Dear Jerome, thank you very much for your presentations. Audience is happy after they have heard you. We appreciate your time. And now we're going to move to Dr. Diego Launstein. Thank you. I will shift to Spanish. Jerome, good night.
Okay, then I'm going to go home and I'm going to go sleep.
Thank you so much, Jerome.
Thank you, Jerome.
Bye.
Thank you.
Bueno, muchas gracias. La doctora Aloha Meave, gracias Aloha por lo que le permitiste tu tiempo al doctor Jerón. Aprecio mucho tu gesto y en función de tiempo Pasaremos ahora con el doctor Diego Lauenstein. Él es el director médico y jefe del servicio de cardiología del Centro de Diagnóstico de Bioimágenes. Él es médico, cardiólogo, ecocardiografista, especialista en imágenes cardiovasculares, particularmente TAC y resonancia, y tiene un máster en eco transesofágico avalado por la Universidad Menéndez Pelayo en Madrid, España. Diego, bienvenido. Muchas gracias por acompañarnos esta tarde. Gracias por tu paciencia y también gracias por tu tiempo. Adelante.
Bueno, muchas gracias. Gracias, Pedro. Gracias, Eric. Gracias por dar el lugar. Bueno, voy a compartir la pantalla. Bueno, la exposición es sobre la modalidad multi-imagen en viabilidad miocárdica. ¿Se ve bien ahí la pantalla? Pues yo la tengo chica. Ahí está, ¿no?
Si la puedes poner aquí, Diego, para que se vea como presentación.
¿Ahí dónde está tu mouse?
Está abajo a la derecha en modo presentación.
Sí, a ver.
Listo.
Ahí. Bueno, muy bien. Bueno, la viabilidad miocárdica en modalidad multiimagen, la charla vamos a tratar de hacerla resumida a su mundo. Creo que cada modalidad es una charla de por sí. Vamos a tratar de mostrar un poquito la experiencia personal, la experiencia de los diferentes grupos en donde trabajo, y hacer un resumen y un viaje por lo que es la viabilidad miocárdica. Como ustedes saben, aproximadamente entre el 1 y 2% de la población adulta de los países desarrollados tienen insuficiencia cardíaca. De ese porcentaje, la mitad tiene fracción de eyección baja. La enfermedad coronaria es la primera causa, en aproximadamente 2/3. Y lo importante en estos pacientes, por supuesto, es la terapéutica óptima y personalizada. Definida la miocardiopatía isquémico-necrótica, lo que hay que hacer es evaluar la viabilidad. ¿Qué es la viabilidad? En la creencia, digamos, en la creencia de muchos cardiólogos, el miocardio está o vivo o muerto, está normal o está necrótico. Lo cierto es que hay diferentes estados, se va desde la normalidad y hacia la necrosis, pasando por un estado en donde la isquemia produce un miocardio atontado, posteriormente la isquemia repetitiva y la caída de la reserva coronaria termina llevándose al miocardio hibernado, y finalmente la muerte celular termina dando fibrosis y necrosis. ¿Qué es viabilidad? Viabilidad es todo aquello que no está necrótico. Viabilidad es lo que va desde normal hasta miocardio isquémico, atontado e hibernado. Con lo cual es miocardio no necrótico con capacidad contráctil disminuida, pero que es potencialmente recuperable. Y este es el concepto, potencialmente recuperable. Esto es un poco lo que yo les contaba, tanto el miocardio normal como con atontamiento, todavía el flujo coronario está conservado, pero hay un estado de hibernación en donde la caída del flujo coronario produce hipoquinesia y con ausencia de fibrosis, con lo cual en estos puntos entre el atontamiento y la hibernación es en donde podemos trabajar. ¿Qué sabemos de la miocardiopatía isquémico-necrótica? Que el volumen de fin de diástole y la fracción de eyección son potentes variables pronósticas, que la presencia de isquemia es un predictor de eventos muy sólida, y que el gold estándar es la recuperación funcional. ¿Qué no sabemos y qué es lo que vamos a ver en esta charla? ¿Cuál es el mejor método para evaluar viabilidad? ¿Cómo y cuándo evaluar la respuesta a la revascularización? Y la gran incógnita es, si tengo un paciente con miocardiopatía isquémico-necrótica y tratamiento médico óptimo, ¿puedo mejorarle los síntomas? ¿Puedo mejorarle la sobrevida? ¿Hay lugar para la viabilidad? Este trabajo es el clásico trabajo de Allman. No hay charla de viabilidad que no muestre esta diapositiva, en donde concretamente lo que se demuestra es, si el paciente tiene miocardio viable y lo revascularizamos, disminuimos considerablemente la mortalidad. Ahora, si no tiene miocardio viable, es mejor el tratamiento médico que revascularizarlo. Entonces acá está la importancia de detectar viabilidad, porque directamente nosotros trabajamos sobre los pacientes que demostramos viabilidad para ir a la revascularización y a la mejoría y a la mejoría de la sobrevida. Mucho se habla sobre el stitch, algo dijo el doctor Bax sobre el stitch. Lo cierto es que la resonancia hace apenas unos años le dio una respuesta publicada en la JACC al stitch, en donde el stitch solamente incluyó pacientes con SPECT y ecodobutamina, y la respuesta al protocolo del stitch fue: la presencia de viabilidad sin revascularización es un predictor independiente de mortalidad. Entonces, constatada la viabilidad, hay que trabajar en revascularizar. Y así fue como muchas de las guías, un ejemplo es la guía europea de revascularización miocárdica, dice que sin importar cuál sea el método diagnóstico, lo importante es demostrar viabilidad y revascularizar a los pacientes. En resumen, en esta introducción que acabo de mostrarles, la extensión de la disfunción del ventrículo izquierdo es el más importante determinante del pronóstico de la enfermedad coronaria. La revascularización mejora la sobrevida en pacientes con disfunción del ventrículo izquierdo. Y la recuperación, esto es un trabajo del Dr. Bax, ocurre entre el 24 y 82% de todos los segmentos disfuncionales. ¿De qué disponemos para producir revascularización y mejorar el pronóstico de vida? De diferentes métodos. Estos métodos son la medicina nuclear, el SPECT y el PET, del cual el doctor Eric es súper especialista, ecoestrés con dobutamina, y la resonancia cardíaca con gadolinio como último método. Vamos a viajar un poquito por estos métodos y tratar de ver comparación de trabajos, qué es lo que hay, y finalmente una comparación sobre qué método elegir para la revascularización miocárdica, para evaluar la viabilidad, perdón. La medicina nuclear. La medicina nuclear evalúa la viabilidad básicamente bajo tres pilares: perfusión, metabolismo y reserva contráctil. La perfusión, todos los métodos de medicina nuclear trabajan sobre la perfusión, sobre el metabolismo solamente el PET, y la reserva contráctil, por supuesto, es cuando uno indica gatillado. Creo que ya son muy pocos los estudios que hoy se hacen en cámara gamma sin gatillado. Hay en algunos países donde todavía existe la ausencia del gatillado, pero es importante para poder evaluar reserva contráctil. ¿Cómo es el SPECT? El SPECT trabaja sobre la integridad de la membrana de los miocitos mediante la captación de radiotrazadores, como pueden ser el mibitecnesio o el talio. Básicamente, aquellos segmentos que captan el trazador por encima del 50% se consideran viables. Y esta discusión de mil congresos y de mil controversias, ¿qué es mejor, el talio o el MIBI? En resumen, los dos tienen una sensibilidad adecuada, 87 de tecnesio contra el 83 del talio. La especificidad es mejor el tecnesio, y aún mucho mejor si se hace con gatillado, cuya especificidad llega al 78%. Además, el gatillado agrega volúmenes, motilidad, fracción de eyección y todos los datos que nos dan los estudios gatillados. El PET. El PET, lo interesante es que usa el amonio marcado con nitrógeno para la medición absoluta de flujo. Por lo tanto, por un lado tenemos flujo y por el otro lado tenemos metabolismo. Entonces, en un mismo estudio hacemos flujo y metabolismo. El metabolismo con 18 fluorodesoxiglucosa, y como les contaba, el flujo se hace con amonio marcado con nitrógeno. El PET nos da diferentes imágenes y 4 patrones característicos. El tejido viable, en donde se ve preservado o incrementado el consumo de glucosa, o sea, metabolismo conservado o incrementado con perfusión normal. El atontamiento, en donde la función se encuentra disminuida en el gatillado, porque si recuerdan, como yo les mostraba la diapositiva de la reserva coronaria, ya está caída la reserva coronaria, con lo cual aparecen disfunciones en contractilidad, pero el consumo y la perfusión son normal, con metabolismo conservado. Función disminuida en el gatillado, pero con consumo, o sea, con metabolismo y con flujo conservado. El hibernado sí, el hibernado ya tenemos baja perfusión, con un metabolismo normal o aumentado, y finalmente la necrosis, donde volvemos a tener match, en donde hay baja perfusión y bajo consumo de glucosa. Acá se ve muy claro en los gráficos, en donde arriba tenemos flujo, abajo metabolismo. En el atontamiento tenemos un match entre lo que es flujo y metabolismo. En la hibernación, esto lo había comentado de manera de diapositiva anterior. En hibernación es que cae el flujo de la reserva coronaria, en donde tenemos caída del flujo y metabolismo conservado, y en la necrosis ya no hay más nada que hacer, tenemos caída del flujo y por supuesto caída del metabolismo. El PET lo que va a demostrar, o lo que vamos a tratar de buscar con el PET, es este mismatch. Con el mismatch demostramos que tenemos presencia de tejido viable, en donde si nosotros revascularizamos, en este trabajo de Di Carli del año 94, está demostrado que la revascularización mejora la sobrevida. Un poquito con aquella diapositiva primera que les mostraba, en donde si el paciente no tiene mismatch, no tiene sentido la revascularización. Entonces, nuevamente, este trabajo vuelve a demostrar la importancia de revascularizar. ¿Cuál es el punto de corte del mismatch? Cuanto más mismatch, cuanto más porcentaje de mismatch aparezca entre flujo, entre perfusión y metabolismo, por supuesto que mejor es el resultado después de la revascularización. Y el punto de corte para demostrar una clara mejoría es del 7%. Si el mismatch está por encima del 7%, por supuesto, los resultados por revascularización son mejores. En el ecostrés con dobutamina, lo que nosotros buscamos es la presencia de reserva contráctil. ¿Y cómo lo reconocemos? La reconocemos por varios puntos y varios parámetros que hacemos en el laboratorio de ecocardiografía. Primero, el aumento de la fracción de eyección. El aumento de la fracción de eyección, por encima de 5 puntos, entre el estudio basal y el estudio de esfuerzo, demuestra que tenemos reserva contráctil. El volumen de fin de sístole debe disminuir. La elastancia ventricular, que ahora vamos a mostrar una diapositiva de cómo se hace, la elastancia ventricular tiene que ser mayor o igual a 2. Tenemos que tener mejoría en el índice de la motilidad parietal. Después el clásico, porque la mayoría de los cardiólogos entienden a la ecodobutamina como la respuesta bifásica a la dobutamina, es quizás el punto más conocido en la dobutamina, que es la respuesta bifásica, el incremento de la velocidad tisular y del strain en el esfuerzo comparado con el reposo, y cuando el volumen eyectivo sistólico, que es el BTI por el área del tracto de salida, en promedio aumenta más del 20%. O sea, que con cualquiera de estos parámetros a nosotros nos dan el parámetro de que estamos ante la presencia de miocardio viable. La fracción de eyección, por supuesto, se calcula por Simpson. Podemos usar los métodos de 2D, 3D, en donde un aumento de incremento absoluto de más de 5 puntos termina dando el parámetro de que estamos ante un paciente que tiene reserva contráctil y que, por supuesto, la revascularización es necesaria. Con respecto al volumen de fin de sístole, en aquellos pacientes en los cuales el volumen de fin de sístole se incrementa en el esfuerzo comparado con el reposo, tenemos mayor riesgo de mortalidad, con lo cual es un muy buen parámetro para reconocer a los pacientes que peor les va a ir como pronóstico, y no es una medición que insuma demasiado tiempo, se hace rápido, es volumen de fin de diástole en el basal y por supuesto en el máximo esfuerzo. Respecto a la elastancia es un parámetro que nosotros hacemos habitualmente en el laboratorio de ecocardiografía, es comparar la presión sistólica sobre volumen de fin de sístole, tanto en el reposo como en el estrés. Y se divide el valor de estrés dividido el valor de reposo, en donde la elastancia normal, como habíamos dicho, es que tiene que ser mayor o igual a 2. Este es un parámetro que no se hace habitualmente. Nosotros hicimos un trabajo el cual publicamos, el grupo nuestro, y en donde demostramos que independientemente que la prueba sea suficiente, y aquellos pacientes que en el laboratorio de ecoestrés con dobutamina, los pacientes vienen beta bloqueados, la reserva contráctil evaluada por elastancia ventricular fue muy útil para estos pacientes con poca capacidad de ejercicio o tratados con beta bloqueados. El índice de motilidad parietal es un poquito lo que yo les comentaba sobre lo que tiene que ver sobre la respuesta contráctil del ventrículo. Picaro mucho escribió sobre esto. Se sabe que nosotros, ¿cómo calculamos el índice de motilidad? Nosotros le ponemos un puntaje a cada segmento que evaluamos en el ecodobutamina, movimiento normal, el puntaje es 1, hipoquinesia 2, aquinesia 3 y diquinesia 4, y en función de esto sumamos la cantidad de puntaje y lo dividimos por el número de segmentos analizados. Eso nos da el índice de motilidad regional. En general, en el ecocardiografía usamos 16 segmentos o 17 según las recomendaciones. En nuestro laboratorio hacemos el de 16 segmentos. Y finalmente lo que hacemos es la comparación entre el índice de motilidad parietal en reposo y con dobutamina, y eso vemos que si hay un delta de más de 0,25, estamos muy probablemente ante la evidencia de miocardio con tejido viable. La respuesta bifásica, por supuesto, tiene un valor predictivo positivo altísimo. La presencia de incremento de la contractilidad en un paciente con 5 gamas de dobutamina y la caída posterior con altas dosis es un alto predictor de presencia de viabilidad. Estamos hablando de un paciente que en reposo tiene hipoquinesia, deterioro severo, probablemente la función ventricular, a 5 gamas mejora la contractilidad, y posteriormente a altas dosis se ve nuevamente caída de la contractilidad y de la fracción de eyección. Como yo les comentaba antes, es quizás el parámetro más reconocido de la dobutamina, y por eso hicimos un viaje por los demás parámetros que terminan dando presencia de viabilidad. Actualmente, algo habló el doctor Batz, estamos utilizando el strain. Aquellos segmentos que en los estudios basales tienen más de 17.2% de strain longitudinal, probablemente nos encontremos ante segmentos viables, y lo mismo, esta misma respuesta bifásica del strain que veíamos en el ecodobutamina, podemos encontrarlo en el strain. Acá hay un claro ejemplo, un paciente que a bajas dosis el strain es bajo, con 5 gamas de dobutamina se incrementa y posteriormente se vuelve a caer. Lo que tomamos como parámetro en varios estudios que incluso hicimos nosotros es un incremento de más de 2 puntos del strain para considerar que probablemente nos encontremos ante segmentos viables. Respecto a la resonancia cardíaca y la presencia de viabilidad, la resonancia nos muestra muchísimos parámetros. Podemos evaluar función, podemos evaluar disincronía, viabilidad, perfusión y estrés. Respecto a la disincronía, que es un estudio que se puede hacer mediante 2 métodos. Uno es el tagging, que es lo que se ve que es crear trazos, es la imagen del centro arriba, es crear trazos sobre el ventrículo y finalmente terminar evaluando deformación. Hoy llamado strain en la ecocardiografía, o mediante tissue tracking, que es los nuevos métodos que se hace solamente sobre imágenes cine. La resonancia es el gold estándar en strain, es la ecocardiografía quien valida el strain en función de la resonancia cardíaca. Pasa que hoy, por supuesto, no es muy habitual hacer strain en resonancia por el tiempo que insume. Entonces, ¿qué es lo que vemos en resonancia cardíaca? Espesores parietales. Por supuesto, los espesores mayores a 5.5 milímetros son viables. Podemos evaluar motilidad, que a diferencia de la ecocardiografía, la resonancia prácticamente no existe en las ventanas. Función ventricular con una altísima correlación inter e intraobservador. Reserva contráctil, lo que vemos es más de 2 milímetros de engrosamiento en la contractilidad miocárdica, y finalmente la transmuralidad que se hace con trance tardío. Por supuesto, es un método confiable y sin radiación comparado con el PET. Entonces, estos son los protocolos que usamos en resonancia. Empezamos por sangre granera, motilidad, los cines para ver función ventricular, podemos hacer estudios de perfusión, estudios de estrés y el realce tardío. Vamos a ver un poquito lo que les contaba. Este es un paciente que lo que vemos es una clara necrosis en el septum interventricular, con un espesor por debajo de 5 milímetros, 4.2 es lo que medimos, y por supuesto, con esto podemos decir que ese segmento prácticamente no va a tener viabilidad. Por otro lado, podemos hacer estudios cine. Este es un paciente donde, por supuesto, lo que vemos es un infarto de la arteria descendente anterior. Encontramos, como les mostraba anteriormente, adelgazamiento y, por supuesto, aquinesia de los segmentos infartados. Probablemente, al no encontrar engrosamiento, nos encontremos ante segmentos que no se encuentren viables. Para función ventricular, como les comentaba, la resonancia tiene una altísima correlación. Es un método que hoy prácticamente muchos médicos nos derivan a sus pacientes para que estimemos con precisión la fracción de eyección. No solamente podemos ver los volúmenes de fin de diástole y los volúmenes de fin de sístole, sino que también, como vemos en la figura, el trazo verde, junto con el trazo rojo del endocardio, nos da la posibilidad de poder calcular masa ventricular. Y con eso todos los índices que son muy fiables en la resonancia cardíaca. ¿Cómo se hace el protocolo de viabilidad o el protocolo de realce tardío de la resonancia? Principalmente tomamos todas las imágenes iniciales, hacemos los scouts, las imágenes basales, estudios en cine, T2 o T1, inyectamos el gadolinio y esperamos 10 minutos. Después de 10 minutos, el gadolinio debería lavarse en aquellos segmentos en donde no existe fibrosis. La fibrosis lo que termina resultando es que el gadolinio quede atrapado en estas fibras, y finalmente 10 minutos post inyección del gadolinio lo que vamos a ver son imágenes con presencia de realce tardío o escara, que en la resonancia se ve hiperintensas blancas. El patrón de realce tardío es en la cardiopatía isquémica es inconfundible. Son las dos primeras imágenes de arriba en la izquierda y la arriba en el centro, en donde el infarto va desde el subendocardio hacia la transmuralidad. Y según el porcentaje de transmuralidad del miocardio afectado, por supuesto que podemos determinar si el miocardio es viable o no es viable, estableciendo como punto de corte 50% de transmuralidad. Esta es la forma en la cual cuantificamos, como les comentaba, evaluamos transmuralidad, y en aquellos pacientes que tienen más del 50% de transmuralidad, podemos establecer que esos pacientes no son viables. Esto es el trabajo de Dr. Wensalf, en el cual, como yo les comentaba, aquellos segmentos en los que el infarto involucre menos del 50% de la transmuralidad, podemos decir que son viables y van a tener mejoría de la función sistólica del ventrículo izquierdo posoperatoria. Nuevamente, para que quede claro, el punto de corte es el 50%, y aquellos pacientes con menos del 50% de transmuralidad tienen viabilidad preservada. Diferentes ejemplos, como verán el de arriba a la izquierda, transmuralidad del 100%, algunos ejemplos de abajo, o los tres ejemplos inferiores tienen transmuralidad del 100%, y los dos restantes son del menos del 50%, con lo cual son los dos pacientes que podemos decir que tienen segmentos viables. ¿Cómo informamos la viabilidad en resonancia? Segmento por segmento y transmuralidad de cada uno de los segmentos. De esta manera, el médico derivante lo analiza y puede ver cuál es el porcentaje de segmentos involucrados. También tenemos la forma, mediante soft, de poder ver cuánto es el área necrótica total sobre el miocardio, en donde en una imagen tridimensional podemos detectar cuál es la escara total, y aquellos pacientes que tengan más del 20% del miocardio afectado por escara, terminan siendo miocardio no viable. La resonancia de estrés es algo muy parecido a la resonancia con dobutamina. Se hace a la ecocondobutamina, se hace a bajas dosis en donde se ve incremento de la contractilidad, la respuesta bifásica, pero a diferencia del ecodobutamina, nosotros finalmente vemos la transmuralidad. Si ustedes ven la imagen inferior, es la única imagen en bordes apicales en donde se comprueba que a bajas dosis mejora la contractilidad, y cuando vemos el realce tardío, la transmuralidad es de menos del 50%. También podemos hacer estudios con adenosina, en donde podemos ver o detectar cardiopatía isquémica asociada, en donde, como ven, en la cara inferior se ve una isquemia subendocárdica al momento de inyectar el gadolinio, la isquemia es subendocárdica inferior. ¿Qué método es mejor? Y terminamos con estas diapositivas. El método mejor, la realidad es que solamente disponemos de una referencia para poder saber qué método es mejor: la recuperación de la contractilidad tras la revascularización. Muchísimos trabajos compararon los métodos de los cuales yo les acabo de explicar cómo se hacen. Hay muchísimos trabajos. Todos los trabajos hablan de especificidad, sensibilidad y efectividad. Son muy parecidos con lo que respecta a los resultados. Quizás el ecodobutamina es el estudio con mayor especificidad, pero el que tiene menor sensibilidad. Con respecto a la resonancia y al PET, son muy parecidas las sensibilidades y las especificidades, y según los trabajos son bastante discordantes al respecto. Lo importante es que la efectividad de todos los métodos es muy alta, y cuando comparamos, por ejemplo, PET contra SPECT, dos estudios que hacen los médicos especialistas en medicina nuclear, claramente el PET es superior respecto a la especificidad y a la efectividad, con sensibilidades muy parecidas, pero lo importante es que cuando se estudió efectividad tras la revascularización, no importa si la viabilidad se demostró con PET o SPECT, la sobrevida libre de evento fue muy parecida cuando se demostró viabilidad ya sea con PET o con SPECT. Cuando comparamos el SPECT con la resonancia, hay un trabajo, varios trabajos, nosotros incluso lo hicimos cuando yo en mi época de estudiante estudiaba en la Fundación Favaloro, lo hicimos a varios corderos, le provocamos infartos y medíamos con realce tardío, posteriormente sacrificábamos a los animales y veíamos el área de transmuralidad. Como ven, este es el estudio de resonancia cardíaca de un cordero, y posteriormente de sacrificarlo, la anatomía patológica muestra una correlación altísima en lo que es la presencia de infarto en resonancia con la presencia de infarto en anatomía patológica. Con lo cual, nosotros tenemos una altísima efectividad de poder demostrar infartos subendocárdicos, que muchas veces el SPECT no los demuestra, con lo cual en aquellos pacientes que tienen pequeños infartos, por supuesto, no estamos hablando de que nosotros vemos más viabilidad que el SPECT, porque son viables los dos segmentos, pero sí tiene una mayor especificidad en lo que sería la detección de infartos subendocárdicos. Resonancia o ecodobutamina es una pregunta que se hace en muchos lugares donde disponen de los dos métodos. Lo cierto es que la ecocardiografía termina teniendo muchísima disponibilidad y muchísima experiencia de los médicos operadores. La ventaja de la resonancia es que no existen las malas ventanas, tenemos una altísima reproducibilidad en absolutamente todas las mediciones, y agrega a lo que hace la ecocardiografía el análisis de realce tardío. En nuestro laboratorio nosotros hacemos reserva coronaria con ecocardiografía, con lo cual no es habitual en muchos centros, pero también si queremos atribuirle una ventaja al eco, es también la visualización de las arterias coronarias, principalmente la descendente anterior en su segmento distal. La lucha del gold estándar. La lucha del gold estándar es la lucha del PET contra la resonancia. Y el PET muestra una realidad, que es una realidad metabólica y de flujo, con estos mismatch de los cuales yo les hablaba inicialmente, y la resonancia tiene una gran ventaja en lo que es la resolución espacial. Entonces, van a leer muchísimos artículos sobre qué método es mejor, sobre qué método nos permite identificar a aquellos pacientes que van a ir mejor tras la revascularización, y lo cierto es que, y la respuesta es, no importa cuál sea el método, lo importante es la disponibilidad en el centro, la experiencia del centro, y por supuesto saber seleccionar a aquellos pacientes a los cuales nosotros vamos a detectarle viabilidad y posteriormente vamos a pedirle su revascularización para la mejoría de la función ventricular. Como concepto, y esta diapositiva que nos enseñan prácticamente desde que entramos a la residencia de cardiología, todos los pacientes con disfunción ventricular severa, enfermedad coronaria de 3 vasos y fracción de inyección, primero determinar si es revascularizable y después demostrar viabilidad. Si demostramos viabilidad, hay que revascularizarlo. Y si no demostramos viabilidad, tenemos que considerar otras opciones. Como conclusión, lo que vimos es que la viabilidad miocárdica se puede valorar a través de diferentes métodos, cada uno de los cuales valora diferentes aspectos, pero como marcador subrogado, lo que nosotros queremos ver es la presencia de miocardio potencialmente recuperable. Por supuesto, en las charlas y en las diapositivas que yo les demostré, quedó evidenciado que la revascularización va a mejorar el pronóstico a largo plazo de los pacientes. El método de elección, por supuesto, es el que se encuentre con mayor disponibilidad y que mayor experiencia tenga el centro en donde trabaja cada uno de ustedes. Y como última recomendación es, nunca revascularicen los pacientes que no tienen miocardio viable. Como última diapositiva, la frase del doctor Nagel y Schuster que decía, no es la cuestión si el miocardio está vivo o muerto, ¿no? O la pregunta no es si el miocardio está vivo o muerto, la pregunta es, ¿qué se necesita hacer para mejorar los síntomas del paciente y el pronóstico? Y dentro de esto entra la opción de tener la viabilidad presente. Poco se conoce para responder esta pregunta, por eso al principio les decía qué es lo que nos queda por conocer, pero estamos trabajando muchísimo para poder responder. Así que bueno, muchas gracias.
Muchas gracias, Diego, inicialmente por tu tiempo y tu paciencia y por la excelente plática en donde nos has mostrado las diferentes técnicas de imagen, sus bondades, sus limitaciones y sus indicaciones. Tenemos una pregunta de la audiencia. todos sabemos que cuando hablamos de viabilidad realmente es un reto y nuestros comentarios están basados en algunos estudios importantes, pero nos preguntan, paciente con disfunción sistólica severa, trivascular, ¿requiere estudio de viabilidad?
Por supuesto, un paciente con disfunción ventricular severa requiere de estudio de viabilidad por un poquito lo que les estaba demostrando. Aquellos pacientes en los cuales tiene disfunción ventricular severa, lesión de 3 vasos y necrosis del más del 20%, no vemos presencia o adelgazamiento por ecos. Lo que les demostré, a aquellos pacientes les va a ir mejor con tratamiento médico o con otras terapéuticas, por supuesto la sincronización cardíaca, pero no es recomendable la revascularización en esos pacientes.
Okay. Una pregunta, te llega un paciente a ecos 3 con dobutamina para determinar viabilidad, pero el segmento lo encuentras muy adelgazado e hiperreflectante, con 4 milímetros de grosor. ¿Vale la pena hacer el protocolo?
Bueno, hay parámetros clásicos de evaluación de viabilidad, ¿no? Nosotros siempre veíamos, ¿no? Aquellos pacientes que tienen R en electro, dolor precordial, por supuesto, son parámetros donde uno presume que hay presencia de viabilidad. La presencia de eco, de segmentos con hiperrefringencia adelgazados, probablemente indica la presencia de transmuralidad, y esos segmentos seguramente no van a ser viables, y no es necesario en esos casos avanzar con otros métodos si queremos evaluar específicamente esos segmentos. O sea, segmentos que por eco están hiperrefringentes y adelgazados es parámetro de ausencia de viabilidad.
Ok. Y eventualmente podemos sentirnos limitados con un ecoestrés con dobutamina para determinar viabilidad, particularmente cuando el paciente está cercano del evento isquémico agudo. ¿Eso te llevaría al paciente a una resonancia? ¿Indicarle una resonancia o qué harías?
Sí, es una buena opción la resonancia. Lo que sí, la resonancia tiene una contra, que es que la presencia de realce tardío aparece después de los 3 a 6 meses. Con lo cual, si estamos muy cerca del evento agudo, por supuesto no vamos a ver la transmuralidad, ni tampoco vamos a estar en el tiempo necesario para que se produzca el adelgazamiento miocárdico. Con lo cual, tampoco es la resonancia el método de elección. Quizás ahí el PET corre con alguna ventaja por sobre los otros métodos.
Gracias. Diego, estamos en el tiempo ya. Te agradecemos muchísimo tu valiosa aportación. Saludos hasta Buenos Aires. Esperamos podernos saludar.
Muchas gracias.
No digo que pronto, pero sí algún día. Muchas gracias, Eric, Aloha, por esta atención. Muchas gracias a todos nuestros amigos que se dieron el tiempo para conectarse y para permanecer. Fueron casi 500 asistentes esta tarde. Y, por supuesto, antes de desconectarnos, expresar nuestro agradecimiento a Acceso Farm para la realización de este importante webinar que fue de alta impacto en la educación médica continua, que es lo que se usa con este tipo de eventos. Y los invitamos a que se conecten nuevamente el martes próximo. Recuerden que se hablará de sincronía ventricular y de terapia de resincronización, un tema completamente vigente, actual y que requerimos solventar muchas dudas. Los esperamos el próximo martes, misma hora. No sé si en el mismo lugar, pero conéctense donde estén. Buenas tardes, saludos cordiales, un abrazo a todos.
Muchas gracias.
Saludos, gracias.
Hasta luego.
Gracias, Pedro, gracias a todos. Bye.
Gracias, Diego. Hasta luego.
Gracias.
Gracias, Marco, también.
Marco, muchas gracias.
Cuídense.
Gracias, Marco. Gracias, Diego.
Gracias.
Gracias a todos.